Welcome everybody to Select Connects with Clinicians. We're going to give everybody just a few seconds to get logged in and called in. All righty. Welcome everyone to Select Connects with Clinicians. Select Connects with Clinicians is an educational webinar series sponsored by Select Data with the goal of improving regulatory compliance and improving patient outcomes. Thank you for joining us as we jump a little bit deeper with PDGM and the comorbidity adjustments that are associated with it. As I'm sure you're all aware, PDGM will incorporate 3 levels of comorbidity adjustments: none, low, and high. During today's presentation, we will break down some of the comorbidity groups and identify common diagnoses that we need to pay close attention to. We want to stress that upcoding is not our goal for your agency by providing this information on comorbidity adjustments, but instead to prepare you for how to accurately capture the true conditions of your patients, the true condition of your patients. Provider documentation, in-home assessments, and multidisciplinary collaboration can help your coding team apply the most appropriate codes and in return assist in getting you the credit that you deserve for the care that you provide for your patients. Presenting today are members of our Select Data Management team. Deborah Johnston is our clinical liaison. And I am Lisa Engel, your host today, and I'm the Director of Onboarding. Before we get started, I do want to share with you our disclaimer. Information made available from this webinar should not be considered legal advice. It is for educational purposes only and does not provide all of the information available on the subject. Information shared is not a promise or a warranty or guarantee expressed or implied. The opinions expressed, discussions undertaken, and materials provided do not represent any official position of Select Data. And now we're going to be joined by Deborah Johnston.
Thank you, Lisa. And thank you all for joining today's presentation. In the agenda for today, we will be reviewing details of Part 1, the classics, and Part 2, the newbies. Earlier this year, we spent some time introducing you to PDGM and the key areas that will require your attention, such as the clinical grouping, functional levels, and comorbidity adjustment. To recap, CMS is moving from 216 to 432 payment groups. There are 12 clinical groupings that are based on the primary diagnosis. There are 3 functional levels that are based on some of the M1800s ADL, IADL OASIS questions, and M1033 risk for hospitalization, and comorbidity adjustment that is based on secondary diagnoses. Keep in mind that this now includes all diagnoses listed on the 485 plan of care, not just the top 5 that are listed on the OASIS dataset. There are 12 low comorbidity adjustment subgroups and 34 high comorbidity adjustment subgroup interactions, meaning there are at least 2 diagnoses that fall into a separate comorbidity subgroup that interact with each other. Let's take a look at the CMS example from their February 2019 presentation. Certain dementia codes, such as unspecified dementia with or without behavioral disturbance, are grouped into the comorbidity subgroup Neuro 3 by CMS. If the patient also has a diagnosis from comorbidity subgroup Skin 4, which includes some of the pressure ulcer diagnoses, then CMS will adjust the comorbidity from none or low to high, since it includes a diagnosis from Neuro 3 and Skin 4, which qualifies as an interaction adjustment. Throughout the presentation, we will reference the comorbidity subgroup names such as Renal 1, Renal 3, Skin 4, and so on, just as a reference. You are not expected to memorize the groups. This table does not include all of the comorbidity subgroups. However, it is clear that PDGM continues to push for ICD-10 coding specificity. Since the transition from ICD-9 to ICD-10 back in 2015, we have been on the path of greater specificity and the decrease of unspecified codes. The purpose of today's presentation is to look at some of those diagnostic statements that are documented by you out in the field and or by the provider in order to focus on the contribution and impact you have in the assignment of the ICD-10 codes. The assignment of the most appropriate ICD code is one of the most important as we transition into PDGM. So let's start with the classics. For anyone that has been in the home health industry for any amount of time, you have probably heard of this infamous list, the list of diagnoses that you always include in the coding of a record. Hypertension, COPD, CHF, diabetes, emphysema, and asthma. We are all familiar with this list. We are going to start today by reviewing some specifics of this list and updating our thought process just a little. The comorbidity group, respiratory 5, will include your most common respiratory diagnoses treated in home care. COPD is another condition that will almost always impact the patient and their recovery. Therefore, it is always captured in home care. However, the specifics are needed not only for better treatment and more accurate plan of care, but also for the coding aspect. Adjustments will not be made for unspecified chronic bronchitis and emphysema alone under PDGM. Therefore, we need to look further for documentation that may elaborate on their respiratory conditions. Also, COPD is not the same thing as chronic bronchitis, so we need to assure we are picking up what truly is going on with the patient. Asthma, again, typically impacts a patient in home care and needs to be a part of the patient's picture that is painted, but the specifics need to be known. Is it exacerbated? Did the provider document it as mild, moderate, or persistent? Those few extra details can make a big difference and should prompt a query to the provider. The comorbidity group, Heart11, includes many of the codes for heart failure. Heart failure is definitely a diagnosis that can impact a patient's progress and typically should always be captured on a claim. The key is coding this condition at the highest level of specificity as possible. There is obviously a trend with all coding and payment source updates. The more specific we can get on the coding, the better. Therefore, reviewing the provider documentation very closely can be key. Heart failure specificity is no different. Being able to code heart failure to the highest level of specificity will depend a great deal on provider documentation. Unspecified heart failure coding will still count toward a comorbidity adjustment, but we cannot stress enough on the importance of obtaining higher specificity if possible. And just a reminder, decompensated simply means a flare-up or an exacerbation of a chronic condition. It is not a particular type of the disease, but rather the status of it. As you review provider documentation to prepare for a home visit, look closely at the details provided, and that alone can assist in more accurate, more specific coding for your patient. Let's review systolic and diastolic heart failure, including how you may see this documented. Systolic heart failure. This type of heart failure is noted with a reduced ejection fraction. This reading must have provider interpretation and cannot be coded based on ejection fraction numbers alone. Therefore, it's imperative to look for that detail and the provider interpretation. Systolic heart failure is often documented as systolic left ventricular failure. Diastolic heart failure. This is also noted as diastolic left ventricular failure. This type of heart failure may be noted with normal ejection fraction, or it may present with preserved ejection fraction. But again, it must have physician interpretation and cannot be coded based on the ejection fraction number alone. Diastolic dysfunction linked to heart failure can also be coded as diastolic heart failure. Here's an example of heart failure documentation by a provider. For this patient, it is worded two ways: acute diastolic CHF and acute on chronic diastolic CHF. With this example, it is described as acute diastolic and acute on chronic diastolic. So how is that coded? We have confirmation of the diastolic heart failure aspect, but is it acute or acute on chronic? That is where further documentation in the facility discharge summary, along with clarification from the clinician, can play a role. Comorbidity group Endocrine 3 includes many of your diabetes coding. Diabetes, as we all know, definitely impacts a patient's overall well-being, from delayed wound healing to causing other complications on a multi-system level. It's imperative to know the details of it when a patient has this diagnosis. Complications of diabetes can range from ophthalmic, circulatory, kidney-related, and so much more. Even if the complication itself is not being treated by the home care staff, the diabetes will more than likely be impacting the care. Therefore, the diabetes with the complication needs to be captured. Do not settle for unspecified. Thorough review of the provider documentation is so important in order to truly depict an accurate picture of the patient. This part of the information will be vital for your coding team to accurately assign this disease process on the patient's claim. The comorbidity group circulatory 4 will include the hypertension and CKD combination codes. The stage of the CKD needs to be identified if at all possible, as this makes the coding more specific and in return more accurate. But the stage is not required in order to receive a comorbidity adjustment when it is part of the hypertension combination coding. Unspecified staging is acceptable. We will discuss how it works if CKD is coded alone shortly, so stay tuned for that. Now let's continue with a few more comorbidity groups that will be recognized under PDGM that the home health industry may at times look over if not careful. With each update in coding and payment sources, there is a stronger sense of importance with higher levels of specificity expectations. The key to receiving the comorbidity adjustment is coding accurately any diagnosis that is being addressed on the plan of care or impacting the patient's current condition. And that is where the coder depends on you, the clinician, and the provider. Your assessment and proposed plan of care, along with the provider's documentation, can guide a coder to assigning the most appropriate, most accurate diagnoses to the claim. So in other words, if there are interventions for a condition on the plan of care, it needs to be coded. If a disease process is impacting the patient's current condition and rehabilitation process, it needs to be coded. A well-thought-out, patient-specific plan of care can assist your coding team to a higher level of specificity in the coding. When documentation is clear and detailed, it can guide your coding team to know which diagnoses are impacting the plan of care. As a clinician, a thorough review of the provider documentation is the best way to obtain that valuable information. Operative reports, H&Ps, medication profiles, and discharge summaries are ways to truly understand what a patient has gone through, is going through, and how they may progress with home care. The comorbidity group, Renal 1, is more of a review, but a very important piece of information has been added. As we have discussed, specificity is more important than ever. This group really focuses on chronic kidney disease. If this condition is coded alone, meaning not part of a combo code such as with hypertension, then it is imperative that the stage is known and captured in the coding. A code cannot be based on lab results. It must be provider verified. There are some key words that are helpful, such as mild CKD being equivalent to stage 2, moderate to stage 3, and severe is stage 4. If the code is left as an unspecified stage, there will be no comorbidity adjustment on the claim. That is why querying the provider for that information is so important. Here we have documentation of past medical history. This specific documentation example clearly states that the CKD is stage 3, and that is what a coder needs to know. If the stage is not noted in the documentation from the provider, it will need to be queried. In the behavioral 2 comorbidity group, if the patient has a diagnosis of depression or bipolar disorder and it is being addressed on the plan of care or impacting the plan of care, that will need to be captured. These conditions can obviously play a role in the patient's well-being and how they respond to the treatment of other conditions, but if it is not documented as such, a coder may not include it on the claim. When assessing and completing the documentation, be sure to address the patient holistically, and if these conditions are not stable, then it should be a part of the picture that is being painted. Here is an example of bipolar disorder by a provider, each with a different level of specificity. These are the types of details that a coder depends on. So if those are available to you, then your coding team will need it also. Heart10 and 12 comorbidity groups contain several diagnoses that, again, if not truly stable, can play a huge role in the patient's overall well-being. When reviewing the provider documentation, interviewing and assessing the patient, be aware of diagnoses such as sick sinus syndrome, A-flutter, AFib, bradycardia, CAD, and angina. These types of diagnoses can make a difference in the comorbidity adjustment on a claim if they truly need to be captured. If any of these are impacting the plan of care or being addressed, that needs to be clear in the documentation. When we think of the classic comorbidities, of course we include conditions that pertain to the heart and circulation. However, under PDGM, we need to expand that thought process. When impacting the plan of care or being addressed on the plan of care, we now need to think of conditions such as aneurysms, atherosclerosis, hypotension, and PVD and PAD, along with acute and chronic embolisms, lymphedema, and varicose veins with ulcers. All of these can potentially impact the plan of care. Our job is to make that determination for coding based on the documentation we have been provided, including provider documentation and yours, the clinicians. Even if a condition is not the focus of care, It should still be counted if you are having to address it or if it is going to make a difference in the patient's response to home care treatment. It paints the full picture, so give yourself the credit you deserve. There are several neurological diagnoses within the neuro 3, 5, and 7 comorbidity groups. Dementia, multiple sclerosis, Parkinson's disease, quadri, hemi, and paraplegia have the potential to drastically impact a patient's response to care. If these disease processes are present and not stable, it's wise to look at provider documentation and assessment findings to see if they should be included on the claim. I'm going to pause here for just a moment to give you time to read this slide. In this example, we can see that the MS is contributing to the need for home health. Therefore, we want to be sure to code that condition. With the neoplasm 1 comorbidity group, it is pretty straightforward. If a patient has an active malignant neoplasm and it is in any way impacting the plan of care or being addressed on the plan of care, it needs to be accounted for in the coding. As you assess the patient and review the physician documentation, be conscientious of how these diagnoses can alter the rehab potential of the patient and express that appropriately in your own documentation and on the home health plan of care. That will clue the coding team that it needs to be included. The SKIN 1, 3, and 4 comorbidity groups include diagnoses that I don't think will often be left out. When it comes to wounds, I think those are typically captured as the home health staff is usually providing care. However, are they being captured accurately? That is where we need to pay close attention. Wounds need to be coded based on the provider-confirmed etiology. That is first and foremost. If that is not evident in the provider documentation, a query will need to be sent so that it can be coded to the highest level of accuracy and specificity. Cellulitis, abscesses, ulcers, both pressure and non-pressure, often drive care for home health patients, including wound care and IV medication administration, as well as other things. Therefore, when these are being captured, it needs to be done so appropriately. We need the details. Site and laterality is a must. CMS would probably get a good laugh if a claim was submitted for a pressure ulcer to the heel, but not sure which, the right or the left. That specificity has to be documented. Also, with your assessment and collaboration with the physician, obtain the severity level of ulcers, as that can impact how it is coded. Thank you, Lisa. I'm going to turn it back over to you now.
All righty. Thank you, Deborah. We just wanted to let everybody know that we appreciate the time that you set out for us to talk about this PDGM that's going to be impacting all of our jobs. If you have any questions, please reach out to us and submit those through an email. And as always, you can keep in touch with us on LinkedIn, Facebook, and on Twitter. Thank you so much for joining us, and we look forward to getting back together with you in a few more months. Have a great rest of the week.